Okay, hi, good evening, everyone, and a warm welcome again to this extremely insightful precision oncology webinar series. And we are again bringing you a very exciting topic, which is very widely discussed across different platforms, across different areas and different organs. The topic of today's panel discussion is Comprehensive HRR Panel or a BRCA1/2 testing. So what works best for PARP inhibitors? I'm sure this would have been discussed a number of times at a number of occasions. So here we have an eminent panelist moderated by an eminent oncologist as well to give you insights about the right panel, the right modality of testing, and what works best for PARP inhibitors. To drive this discussion, today's session will be moderated by Dr. Chandrakanth MV, who is the consultant medical oncologist and hemato-oncologist at the Narayana Health in Kolkata in India. We have an eminent panel of panelists, Dr. Mofazzel Hossain, who is the chief consultant medical oncologist at the BRB hospitals, Dhaka in Bangladesh. Dr. Rolan-Ohmar, head of medical oncology at Victoriano Luna Medical Center, which is under the Armed Forces of the Philippines Health Services Command in Philippines. Dr. Bijesh Ghimire, senior cancer specialist, medical oncologist at Nepal Cancer Hospital and Research Center in Kathmandu in Nepal. And Dr. Vinu Sarathy, consultant medical oncologist at the Bangalore Baptist Hospital. With this introduction, I would now like to invite Dr. Vidya Veldor, our clinical director, to start the session and also take on the Q&A at the end of the session. Dr. Vidya, the floor is yours.
Thank you, Ramesh, and a warm welcome to all of you again. Today's topic of discussion is what is beyond BRCA1 and 2 testing that can help in decision making for PARP inhibitor therapy. And here comes the HRD score and the HRR panel. So before the panel discussion starts, we are just going to relook into the fundamentals and try to know the know-how of what happened in the past and where we are in our understanding of HRR panel and what is the underlying biology behind this genes and their pathogenic alterations. Without much delay, I will quickly walk through. So way back, the very first assay in this pathway of looking at homologous recombination and repair deficiency and how this deficiency could be used as an advantage to kill cancer cells. The very first assay which was developed and FDA approved is the Myriad Genetics HRD assay. And this particular assay constitutes multiple components. And the first component is looking at BRCA1 and 2 gene sequencing for the coding regions and trying to arrive at pathogenic alterations in BRCA1 and 2. Then we have the the contribution coming from promoter-methylation, and then you have the other homologous recombination gene mutations and several other mutations. These are all the factors which can contribute to homologous recombination and repair deficiency. Now the Myriad assay primarily constitutes not only the BRCA1 and 2 mutation, it also has three major components: the loss of heterozygosity and the telomeric allelic imbalance and the large scale state transitions. All these four factors put together, Myriad arrived at a score called HRD score, which is proprietary of the Myriad assay, and a score greater than 42 is considered as positive and the patient's tumor is sensitive to PARP inhibitor therapy. Now, this is the story which we know for the last decade. Now, after that, there have been, based on the score, as well as looking at the mutations in the HRR pathway, several clinical trials were conducted in the last a decade or so. And the outcome of some of these clinical trials has given us a lot of significant insights in 4 major cancer types, primarily the breast, ovarian, pancreatic, and prostate cancers, wherein germline or somatic BRCA mutations, as well as some of the HRR gene mutations, has pathogenic alterations in HRR gene mutations, has given a significant correlation towards improved progression-free survival and overall survival in some of the clinical trials, along with the HRD score, which is considered to be one of the landmark discoveries, and also that continues to remain one of the important critical decision-making factors for PARP inhibitor therapy. So to begin with, in breast cancer, we all know hormone positive or the HER2 negative group. Either one of these cases, when there is a germline BRCA mutation, Olympiad trial is one of the very early trials where they looked at those patients with metastatic breast cancer and germline BRCA mutation, patients who did not receive prior chemotherapy on the olaparib arm showed a significant improvement in survival as compared to those patients who received chemotherapy. This is one of the things. This is about the tolerability. Then moving on to the ovarian cancer, here again, high-grade serous ovarian cancer, which is epithelial ovarian cancer, and which is known to be platinum sensitive. 3 different lines of PARP inhibitor therapy, primarily the olaparib, rucaparib, and niraparib, were tried in multiple clinical trials. Some of them are listed here, like the MONO-2, then the SOLO-3, and the Ariel 3 and 4, and then the ENGOT Nova trial. In most of these trials, the main scope was to look at when there is a relapse in platinum sensitive high-grade serous ovarian cancer, how did olaparib or any of its similar inhibitors like rucaparib and niraparib has helped in improvement of the progression-free survival and overall survival. Initially, the approval came as second-line maintenance therapy in the recurrence setting. So this is the journey again. I won't be going into details because Dr. Chandrakanth sir will be giving a lot more insights into all these trials as we discuss the case studies. Now, the third important trial is around the prostate cancer in metastatic castration-resistant prostate cancer. This is the PROFOUND trial. It's a phase 3 trial where they grouped the patients into 2 cohorts. Those patients who were positive for BRCA1 or 2 or ATM alterations pathogenic, and the other group had the other pathogenic alterations, and then they randomized it and they gave olaparib and then the physician's choice in both the arms, and then they looked at the PFS and OS. So when you see this, those patients who carried the pathogenic alterations on olaparib showed a significant improvement in progression-free survival as compared to the standard of care AR therapy. So this is an overall survival curve. Now moving on to the pancreatic cancer in advanced setting, platinum sensitive. Here again, germline or somatic BRCA1 and 2 or PALB2, which again constitutes one of the members of the HRR gene panel. They have observed that presence of these mutations has an increased sensitivity to response to olaparib. This is one of the survival curves showing the improved survival, overall survival. So waterfall plot showing again how there has been an improvement in the patient's disease. Now going to the biology of the DNA repair process, HRR and PARP inhibitors. So how many different ways mutations can happen? This one is a base mismatch, a change in one alphabet. Sometimes there is a break in a single strand. Sometimes there is a break in both the strands. Sometimes there is a crossover that happens between the two strands. And sometimes there is cross-linking that happens between the both. Sometimes there are some external chemicals which bind to the DNA and then they form adducts. Due to all these factors, the native structure of the DNA is lost. When the native structure is lost, body senses that there is a mistake that has happened and one has to go back and repair this mistake. What are the pathways that exist which are currently working in any healthy cell in a human being? Are the set of pathways that are mentioned below here. These pathways get activated, they go and attack the site and then they repair. If any one of the genes in these pathways are mutated or lose their function due to a pathogenic alteration, essentially when you say pathogenic alteration, the alteration results in loss of function of that protein, because of which a disease is onset, that is a pathogenicity gets onset. And hence these pathways become very, very important as one of the primary repair mechanisms to take care of the human cell while it goes through multiple levels of replication process. This is again a cartoon showing two different primary pathways, the homologous recombination and the NHEJ pathway. And then the PARP enzymes, or rather the HRR enzymes, work primarily in this pathway. And this is the set of genes which are involved in homologous recombination repair. Not though all the genes, but some of them have been part of the PROFOUND trial, and primarily the 15 genes, which is currently being recommended as one of the screening protocols to look for any damage in the HRR pathway. So this is another cartoon that shows that the PARP enzyme being the central player, how it has an impact on multiple different pathways which are associated with DNA damage and repair mechanism. So this is another network. So essentially here what we see is that how in each different type of mutation, what is the cluster of genes which are involved, NBN, MR11, RAD50 is involved in double strand break repair. And here the single strand repair is taken care by ATM plus these cluster of genes. Then how each repair mechanism is being taken care of is being shown here. So this is another cartoon that shows how exactly the PARP enzyme works. And in the interest of time, I will be going through very quickly. This is the list of some of the trials where screening was done for the mutations in the HRR genes, and subsequently the response was assessed. The overall survival and progression-free survival was correlated to the mutation status. So this is the consensus from the ESMO guidelines, where it clearly states that what are the genes which are very, very important to be looked for other than BRCA. What are the other HRR genes that are very important in order to take a decision on PARP inhibitor therapy. This is the journey of different approvals, timelines approvals for PARP inhibitors in different malignancies. Now, I pass it on to Dr. Chandrakanth sir. Sir, the floor is yours, and thank you for your time and attention.
Dr. Vidya, Dr. Chandrakanth is having some technical issue for joining in.
Okay.
So maybe you could start and then Dr. Chandrakanth will take over as soon as he joins.
Okay, so all the panelists are here, right?
Yeah, everybody's there.
Okay. file. So having said that, we have gone through the fundamental details about what is the homologous recombination and repair pathway, and then what are the important key landmark trials where the approvals were obtained for different PARP inhibitors. Now we move on to different case studies, indications where how clinical decisions are taken to screen for mutations. Either is it only BRCA1 and 2 or the extended list of HRR genes. Case 1 is Mrs. Daisy, aged 65. She is a known case of metastatic CA ovary, and pathology shows high-grade serous ovarian carcinoma, and she has no family history. She was treated with 3 cycles of neoadjuvant paclitaxel and carboplatin. Post-surgery, after 3 cycles of chemotherapy, the clinician wanted to explore PARP inhibitor options for her. So he had sent for HRR testing. Now the question is, when do we need to do the HRR testing in high-grade serous ovarian carcinoma? Sir, can you please start as a panelist, sir? Dr. Mofazzel, and can you please give your comments?
Yes, good afternoon, everyone. It is my immense pleasure, and I express my deep gratitude to Core-Based Care for arranging such a nice clinical meeting and case discussion. And about the first case, it is a high-grade serous carcinoma. We all know the high-grade serous carcinomas are notorious, most of them present in an advanced stage. And from literature, we know that about 50% of them have this genetic alterations. So I think those who present in an advanced stage, like this patient, as she presented in a metastatic state, so I will recommend the HRR testing at the very beginning. This may help subsequently for treatment by the PARP inhibitor as maintenance, because most of the tumors of high-grade serous carcinoma variety are initially chemosensitive, and eventually they become chemo-resistant, platinum-resistant. Then we don't have much of options other than those bevacizumab and second-line chemotherapy. But with PARP inhibitor, as we all know, there has been studies, as in several of the trials have shown that there is both increased progression-free survival with PARP inhibitor. So if we test it and it comes positive, that will be of very good use to the great benefit of this patient. Thank you.
So in your country, is HRR testing expensive, and do you do only HRR testing, or you have patients who can afford to go for an HRD assay?
Right. In this connection, I want to say a few words. When we advise a test, we consider several factors about that, or several aspects of that test. Number one, availability of that test. Number two, interpretation of the results. And initially, of course, there should be a definite indications, as I said, in high-grade serous carcinoma, the initial presentation with the metastatic stage. So there is indication. Then the other point is cost and availability. And it also depends upon the counseling of the patient. About the availability, as you asked me, well, in our country, it is not available. We can only do the BRCA1, BRCA2, but other HRR alterations, we cannot. So we send the samples most of the time abroad, maybe in India or other countries, and the results are obtained about 2 to 3 weeks later. So this is the state in our practice now.
Okay, sir. Fine. So just to add on, what would be the ideal specimen that we need to take for looking at either BRCA testing or the HRR testing in ovarian cancer?
I think it's better if we get the tissues, but in some cases when it is not available, it can be also considered, I think, from the liquid biopsy, I mean the blood samples.
Okay. And there is one small note. Being a scientist from the laboratory side, I just wanted to add one note here, sir, for the interest of all of us in this learning. Due to the neoadjuvant chemotherapy, most of the tissue gets necrotized, and then the DNA quality is not so good post neoadjuvant treatment when the surgery is done. So that particular specimen may or may not be the right specimen to look for somatic alterations. However, the primary biopsy material could be the right material because it has not seen any chemo, and the quality of DNA might be slightly much better as compared to the neoadjuvant chemo treated tissue specimen. That's one small addition that I wanted to add on to this discussion here. Okay, sir. So thank you, sir. And the next case here is Mr. John, 73-year-old male, diagnosed with CA prostate. Histopathology is adenocarcinoma, Gleason score 7. He does not have, again, any family history. He has comorbidities. He has coronary heart disease, and then due to his age and other comorbidities, the oncologist chose not to give him chemotherapy, and he wanted to explore PARP inhibitor therapy. Therefore, he sent it for HRR testing. So what is the role of HRR testing in late onset prostate cancer, and how does this help in management of the disease? Dr. Bijesh, can you please share your experience?
And thank you so much for this experience and for such a nice webinar on HRR panels. As Dr. Mofazzel has already said, we in our country also, we don't have HRR testing at present. So we have to send to India, and cost issues and patient, even if they are PARP positive, not being able to afford drugs, olaparib or other drugs is also a very pertinent problem for us. But as a clinician, so far I haven't used or sent HRR in CA prostate patients. But according to the guidelines, this HRR positive metastatic prostate cancer can be treated with PARP inhibitors. So there is, of course, a role of HRR testing in a patient with metastatic pancreatic prostate cancer.
Sir, Mofazzel sir, you want to add something more to this?
Yes, I fully agree with what Dr. Bijesh has said. You have already mentioned about the studies that have shown the role of PARP inhibitors in the management of metastatic prostate cancer. Right. This is possible in, this is actually the studies were in HRPC, but as the gentleman is about 73 years old, having a coronary artery disease, So he is a good candidate for treatment with PARP inhibitor, provided some kind of HRR alterations are there. So initially we can send this for testing, HRR testing, and if he is lucky to be positive in any way, then probably we can put him on the PARP inhibitors. But if we practically say in 73-year-old CA prostate, he is not yet MRPC or CRPC, so he can be well treated by drugs which are not very detrimental related to the coronary heart disease, such as the GnRH, not the analogs, but the not the agonist, but the antagonist can be safely used, more safe. They are more safe. I cannot say safely, but they are more safe than the agonists. And again, the point that was raised by Dr. Bijesh, the cost is an issue. The prostate cancer patients, many of our patients are very poor and they cannot afford this. Even they cannot afford the Zoladex or the other GnRH analogs. So we have to put them just on the anti-androgens. PARP inhibitors are a little costly, but many of the PARP inhibitors are being now produced in our country. And so they are becoming a little cheaper day by day. So hopefully in future, we will be able to use it for our patients. And the tests are not available. So again, we have to depend on the neighbors. We are so grateful to them. Thank you.
Thank you, sir. So do you recommend in absence of tissue biopsy, suppose his performance score is not so great, in absence of tissue biopsy, would you recommend liquid biopsy in such a patient at baseline to look for HRR mutations?
Well, liquid biopsy is always an alternative to the tissues, because previously we used to say tissue is an issue, but obtaining a tissue is difficult, particularly if the patient is old and frail, and a risk is there for surgical intervention, invasive tests. So we can try with we can send the liquid blood for testing this HRR BRCA germline testing as well.
So just to add on to this comment here, sir, liquid biopsy based profiling, particularly at the baseline for metastatic castration resistant prostate cancer, has been well approved in the laboratory setting, particularly the European Molecular Quality Network program, which closely works with ESMO and other international guidelines. They have come up with a proficiency testing program where we look at the cell-free DNA based screening for HRR mutations in any prostate cancer patient who is not eligible for a tissue biopsy. And the same liquid biopsy can be used as a monitoring tool during the course of treatment to assess the response to therapy. So this is one small addition, and I just wanted to share this with the medical community. So Dr. Roland, would you like to add some notes here on this case? If you were to treat this patient, how would you do this?
For this patient, an advanced prostate cancer patient, I believe, if I'm going to ask for an HRR, probably literature says it's around it. It's in about 30% of prostate cancer cases. So, and the data also supports the use of PARP inhibitor, but mostly for BRCA1 and 2 positive and not so much for other gene mutations with homologous recombination deficiency. However, there is data in giving upfront PARP inhibitor, particularly olaparib, in combination with abiraterone. In this case, HRR testing isn't even needed, and it's shown to have significant benefit.
Okay.
Probably because of synergistic effect of the two drugs.
And I wanted to add something in prostate cancer. If it is like liquid biopsy is one option, but if the patient is not able to do fresh biopsy, the biopsy which we had taken earlier, even if it is kept in a proper condition for a few years, maybe up to 10 years, can be used for HRR testing. And also the metastatic, especially because prostatic cancer is metastasis mainly to bone. So bone biopsies are not a very good specimen for HRR testing. So old samples are also equally good in prostatic cancer for HRR testing.
Dr. Vinu Sarathy, sir, can you please, share your thoughts and how would you treat a patient like this in prostate cancer?
Good evening. Thank you for the opportunity, and it's an honor to be part of the forum with such senior and eminent oncologists. Here, like Dr. Hossain sir said, he's a naive patient who's never been treated. So always our principle would be first is androgen deprivation. So I think we would never choose first a PARP inhibitor upfront. So I think even though he has a coronary artery disease with GnRH analogs, we have seen, and with effective coronary artery medications, the incidence of coronary artery disease exacerbation has not been too much. So we always reserve HRR testing in the first relapse, either biochemical relapse or a radiological progression, where we would try for a repeat biopsy, and if not possible, then we would try to do a liquid biopsy, and then only plan HRR testing and further PARP. I think first initial treatments remains the same, and it would definitely be androgen deprivation therapy.
Okay, thank you so much, sir.
Dr. Vidya, Dr. Chandrakanth has joined.
Okay, so I will, pass on this to Dr. Chandrakanth, sir. Sir, kindly take over. I will stop this presentation. I can move the slides for you.
No, I think we can continue discussion from the point where you started. So just hold on. Yeah. So I think we were discussing on prostate cancer and the implications of HRR testing. So I think we all agree that the most important treatment for prostate cancer is ADT, and definitely HRR testing should be done in our practice. Okay, so my personal experience is I would of course reserve HRR testing to be done in a CRPC setting. I would not do in a hormone sensitive setting. In a CRPC setting, after I have exhausted the initial androgen deprivation therapy, I would definitely do. So I would do it for various reasons. Most important is to use PARP inhibitors in this present space. And the second reason is familial, so what is the family history the patient has. So I would also look at their first and second and third degree relatives who will be at risk, and so that we can put them on a screening protocol. So for these reasons, we usually do HRR testing. So we do HRR and also germline BRCA testing if we really want to see whether it is germline or whether it is acquired. Okay, so this is how I would look in my practice. Okay, so I would also ask the other panelists as to what they would prefer. Would they prefer tissue, or they prefer blood, or do you do a rebiopsy in the CRPC setting, or do you use those archival specimens which were there in the baseline. Okay, can anyone guide me who was the panelist available to be asked?
Sir, we went through all the panelists in one round, sir. I started off with yes, Dr. Mofazzel.
Okay, just in the same order, you just guide me. You can just ask the next panel. I'm just going through. Yeah.
Okay. So, so this question, actually, we did have a brief discussion. Dr. Bijesh mentioned that he might want to choose an older block, the diagnostic specimen, which is available in the FFP format, to go ahead and look for HRR testing. And again, Dr. Mofazzel reserved the relapse setting, as you rightly said, that it has to be in the relapse setting, but again, rebiopsy if possible, otherwise liquid biopsy. And Dr. Vinu Sarathy sir also mentioned ADT, and if there is a relapse, then only look for HRR status on a fresh biopsy. And then Dr. Roland, could you kindly share your thoughts on a case like this? How would you handle if it comes in the relapse setting or in the primary setting?
Yes. If it came in the primary setting, if financial considerations aren't, if finances aren't part of the consideration, I would probably start the patient off with an abiraterone plus a PARP inhibitor of olaparib already, even without waiting for an HRD testing for this case, because of the data of the Propel trial, wherein the benefit of giving the two drugs at the same time showed that it was sustained a lot more, a lot longer than just abiraterone alone.
So So we also looked into the testing the archival specimen. So we found that up to 40% chance that the tissue was inadequate to get a proper somatic BRCA getting done. So I would also ask Dr. Mofazzel. Dr. Mofazzel, if you use the archival specimen in your setting, so are you also able to get this report that the quality check is not good or the tissue is inadequate? So how do you look at this challenge of using the archival specimen?
Actually, this will be totally a theoretical discussion on my part, because when the patient is HRPC, I do not treat with PARP inhibitor, because these things have come out very recently, isn't it? Approval has been obtained lately. So I still go for chemotherapy, but if the patient is unfit for receiving the standard way of delivering chemotherapy, then I do modify the chemotherapy drugs, maybe some weekly or 2-weekly regimen. I will try to obtain a tissue. If it is adequately obtained, fine. Otherwise, liquid biopsy, as Dr. Bijesh said, it is equally acceptable and recommended. So liquid biopsy is very easy. It can be sent for the testing.
Okay. So, Dr. Vidya, so
Yes,
if we look into the liquid biopsy, we are looking into the germline HRR. That's what we are looking into, right? Or we are looking into germline BRCA. So there can be instances where if you do a somatic testing in the tissue, you will be picking up higher number of mutations. You are actually seeing into the effect if I am looking into the somatic BRCA. So if you look into the clinical trials, all of he was just naming the PROFOUND trial. So what they did was they looked into the tissue BRCA. So how will you look? What would you recommend? Should you do a tissue BRCA or should I look into the germline HRR?
So there are 4 things here, sir. So let me clarify once again. So we are looking at germline mutations. That means to say every cell in the body carries these mutations, right? And BRCA1 and 2 are integral part of the list of HRR genes, right? So we have only 2 major categories, that is BRCA positive HRR or non-BRCA positive HRR genes. So the non-BRCA positive HRR genes are these like PALB2 and the RAD series, and then ATM check and others. So to come back to your question, if we are going by tissue, the primary diagnostic material tissue would be the ideal choice to look for mutations, both somatic as well as germline. However, we will not be able to distinguish between the two because the tissue specimen that we pick up has both malignant cells and the neighboring normal cells. In addition to that, the malignant cells are actually derived from the normal cells. Therefore, the inherent mutations would still remain. Nevertheless, we cannot kind of quote unquote stamp it and say that this is germline. The reason being the source of the specimen is the tissue, that is the tumor tissue. However, if we are looking at blood sample and germline testing, then we are very confident, particularly the WBC as the source of DNA, then we are very confident to say that it is a germline mutation. And recently, there are many more evidences which are coming up where we are able to detect germline mutations in a liquid biopsy setting with high confidence, in as high confidence as a WBC based source of germline DNA. The reason being, liquid biopsy has a cell-free DNA which is derived not only from healthy cells which are in circulation in the peripheral blood, but also from the DNA that is shredding out from the tumor cells, which is the cell-free tumor DNA. Therefore, if you look at liquid biopsy profiling, we are getting not only the information on the somatic mutational landscape, we also get to see the germline mutational landscape with much higher confidence than the tissue. So both of them, I would say, they complement each other. To summarize, if there is a challenge with the tissue in terms of its quality and you don't get adequate depth and there are some challenges with coverage of certain genes, then liquid biopsy becomes the next possible option where we can screen for both somatic and germline mutations. Am I answering to the point that you asked?
Yes, I think you made it very clear, Dr. Vidya, that when to do what and what are the pros and cons of each one of the tests. Okay.
Yes.
I think we have had this enough discussion on the prostate part. Okay, let's go to the further slides. Okay, next slide.
Yes.
Go to the next
Yes.
slide. Okay. So this is a 35-year-old lady diagnosed with right-sided breast cancer, IDC triple negative, strong family history of cancers as denoted in the pedigree. So when is the ideal time to get HRR germline testing done for PARP inhibitor treatment? So should we do a diagnosis? Should we do it at the completion of chemo? Should we do a relapse? So that is the question. Okay. So I would request Dr. Bijesh to share his experience on doing BRCA HRR testing in a triple negative young localized breast cancer with the curative intent.
This is a 35-year-old female with a strong family history and breast cancer. So I would, the best ideal time for HRR testing would be upfront, and would be upfront testing would be the choice. Here being the region, first we need to find out the germline, to do the germline testing to see the hereditary panel for this patient, and also because in a triple negative patient, we are germ cell who are positive for PARP inhibitors. the response of chemotherapy is better, and that there is a chance of complete pathological response for these patients. And also there is the Olympia trial, which has said that if the patient is not pathologically complete remission, we can give maintenance olaparib for this patient. So I would do first upfront HRR germline testing for this patient.
Okay. I think the similar thoughts is what we all also would echo. Doing HRR or doing BRCA mutation would have an implication on the present treatment, the type of mastectomy, the type of follow-up, risk reduction, salpingo-oophorectomy, and also on the family members. Perfect. So, well, Dr. Vidya, so I have a doubt, what happens is, supposing I did a test for a patient and the test came out as, let us say, BRCA1 mutant. Now, I would have a genetic counseling for screening the family first and second degree relatives. So, is there a facility of doing only that allele, only that particular mutation? There is no need of screening BRCA2. There is no need of screening all the HRR for these patients. If a patient has a BRCA1 mutation in a particular sequence, I think you will look only that sequence in all others, or you again do a BRCA1, BRCA2 HRR for all other family members.
No, we only look for that particular mutation in all the first and secondary degree relatives in this family. And it is done by Sanger testing on the individual's peripheral bloods.
So then I think the initial screening, we would do an HRR as to find out the culprit gene, and that is expensive. But to do the Sangers for rest, all of them becomes, economical, and it won't have so many cross implications. Yes. I think this is very important take-home message, that if we have a particular, sequence, a particular gene that is actually mutant, we can repeat the same test in all of them only in that Sanger sequencing, so that we don't do unnecessary testing for all the family members. I think those are very excellent points shared by Dr. Bijesh and Dr. Vidya. Okay, go to the next slide. Let's quickly go through the future cases. Okay, so this is the fourth case. Okay, so I would request Dr. Vinu to look into this. So this is a 42-year-old lady diagnosed with ovarian cancer. It's a high-grade serous adenocarcinoma. Oncologist was contemplating using PARP inhibitors, hence sent BRCA1 and 2 gene testing on the blood and block, which was negative. So this is important. So this patient, high-grade ovarian cancer is a disease where the patient is going to relapse. The whole challenge is to preserve the platinum-free interval or the progression-free interval. So if you have a germline BRCA that is negative, so what all other tests will you do to find out whether this patient is going to be eligible for PARP inhibitor? Dr. Vinu, your thoughts on these questions?
Yes, sir. Thank you, sir. So currently, as of such, we are recommending somatic BRCA and HRD for all our patients. Thanks to the free coupons we are getting, we have access to do the HRD and get the GSS score, the genomic instability score. So as of today, we are not just looking at BRCA 1 or 2, but the complete HRD, which is the effect, and we are looking at the score. As we know, we can offer them PARP inhibitors as maintenance in the upfront settings.
Very correct, very correct. So we don't just see the BRCA, even if BRCA negative, BRCA positive is around 15-20%, but those patients who are eligible for PARP inhibitor is up to 50%. The whole effort has to be made by HRT. Okay, I would again request Dr. Vidya. Dr. Vidya, so we have so many, HRT by Myriad, HRT by Foundation One. So what type of HRD do you do in 4-based care, and how sensitive the HRD we do in the Indian scenario to replicate those that are done in the randomized clinical trials?
To be my submission, we do not offer HRD scoring at 4-base care, sir.
Okay.
We only
Okay.
look at
You
HRR
only
gene
HRR.
mutations. Yes.
Okay. Okay. So because so in HRD there are so many minor like LOH, telomeric instability, large space insertions, and so on. Fair enough. So I think if you have got an HRD, then you must find out an HRR to find out which is that culprit gene.
Yes.
Okay. So this is about ovarian cancer. Okay, let us go to the next slide. Okay, so pancreas cancer and HRR. This is a 50-year-old male with a pancreatic cancer, adenocarcinoma. So again, I would go back to Dr. Rolan. Dr. Rolan, in pancreatic cancer, when do you think of HRR testing? What is your experience in your clinical practice, Dr. Rolan?
Actually, I'm just familiar with the data with olaparib in these cases, particularly with the POLO trial. And in the POLO trial for metastatic pancreatic adenocarcinoma, they only tested for germline BRCA. So I'm really not sure about the HRR testing in this case. Although it was mentioned earlier, I think with rucaparib as a phase 2 trial, but I wasn't able to look into that data myself. So in my practice, I just request for germline BRCA and not for HRR. And actually, I really don't know how the incidence of homologous recombination deficiency mutations in metastatic pancreatic cancer. At least in BRCA1 and 2 mutations, around 5%. So I'm really not sure in this case if how much patients would benefit from testing with HRR.
True. So any experiences of PARP inhibition in pancreatic cancer in your setting? Is it productive to use PARP inhibition in pancreatic cancer?
I'd use it if I catch a patient with BRCA mutation. Unfortunately, for the few cases that I've sent germline testing for BRCA mutation, none so far has come back positive.
Okay. So I would request Dr. Mofazzel. Dr. Mofazzel, we have so many indications, breast, ovary, pancreas, prostate. So in your clinical practice, which are the patients you make sure that you send for BRCA mutation, and how easy it is, the access is good in your country? And what about PARP inhibitors? How effective are they in your practice in all these 4 indications? Dr. Mofazzel.
Well, to be very honest, I do practice PARP inhibitors only in 2 indications so far. There is breast cancer and ovarian cancer. I do test for BRCA1, BRCA2. If they come out to be positive, we use it. Olaparib, or even if BRCA1 and 2 are negative, we can try with some niraparib that is effective even if BRCA1 2 negative. So I do practice that in many of the breast cancer cases. But the effect is not very impressive. If you ask me, honestly speaking, the effects are not very impressive. I am not very impressed because with so much money spending, at the end of the day, if you don't find at least 4, 5, 6 months of progression-free survival, then it doesn't make sense to spoil the poor man's this money. So I do practice in 2 cases, these 2 settings, when all other options have exhausted. And for pancreatic, I have not yet used. For prostate cancer, maybe I will be using very soon, not yet started.
I think,
I think it's the same thing with me, because I have not so far sent any patient CA pancreas for HRR testing or BRCA. So I'm also very curious to know what has been the experience from you, Dr. Chandrakanth, or anybody on this thing, because I have not.
True.
But
Yeah.
To tell you frankly, I treat many of the cases of pancreatic cancer, and definitely most of them do present in advanced stage and metastatic stage. But unfortunately, as Dr. Bijesh said, I have not yet even advised this BRCA or HRD test. Maybe after this session, as we are enriched with more knowledge, we will be sending in future.
Excellent, sir. Excellent. I think Dr. Mofazzel and Dr. Bijesh, both of them have, hit the bullseye, where we do not do BRCA testing routinely for pancreas and also for prostate. And it is for a reason. If you look into the level of evidence for PARP inhibition in ovary and in breast, the hazard ratios are excellent. If you look into the Olympia, there is overall survival benefit. And then if you look into the Solo 1 and the Solo 2, both, so the hazard ratios are excellent. We see some good results in ovary and breast. Whereas if you look into the clinical trials in prostate and also clinical trials in pancreas, it's a progression-free survival benefit. And remember, in both of these trials, the comparator arm was weakened. In Polo, they used, observation or a placebo, and whereas again, in also prostate, also the comparator arm was not that strong. Therefore, the hazard ratios are not that great. And as Dr. Mofazzel said, it is not that promising if you use even that expensive drug. So we should be very judicious in offering PARP inhibitors in our clinical practice. These are not magic drugs. We need to do testing, yes, but whether to offer or not is, of course, discussion and discretion at that point of time. Okay, I think we had excellent discussion. Okay, you have any slides? Can you go to the next slide?
I have one point to share here, sir.
Yes,
In
yes,
our
please go ahead.
experience in genetic testing, we have come across somatic mutations in RAD series, RAD51C and D, in pancreatic cancer patients. In a couple of instances, we did come across RAD51 mutations in germlines also in pancreatic cancer patients, as well as in prostate cancer patients. Although BRCA is there, but predominantly when there is BRCA mutation, the phenotype is mostly HBOC kind of a phenotype. But when there is pancreatic, probably there are other genes that are showing up the pathogenicity. This is just a observation, but how it is being used in the clinic is something like what you just now discussed, probably that you would take a call on a case-to-case basis maybe. But we have seen strong driver mutations, which are like the underlying cause for the disease in both these cancer types. We started seeing that even in cholangiocarcinoma.
Excellent, excellent. So,
Yes,
Dr. Vijay, you tell me one thing. If I have sent a tissue for a BRCA mutation and the tissue is negative for BRCA mutation, okay, then does it make any sense in sending a germline BRCA? So I am just adding to the question. If you look into the technology of doing a somatic BRCA versus a germline BRCA, I think for somatic BRCA, you need a better technology and the chances of false negatives are high. So do you agree that we must do a germline BRCA even if somatic is negative, keeping in mind that the tissue may not be preserved well, the technology for a BRCA will not be good?
So as you rightly said in the last point, in some regions of the BRCA gene, when we sequence it using the tumor DNA, there may not be adequate depth of coverage. And there are chances that we do not get enough read support to adequately read that region coming from the tissue specimen. Therefore, in those scenarios where the clinician has a strong suspicion that there is a high possibility of BRCA being positive, if this tissue BRCA turns out to be negative, germline BRCA is suggested to complete the cycle of exploring the possible BRCA options.
Okay, I think it is very clear, by your words, when to do germline and when to do somatic and when to do HRR look for non-BRCA. So again, to add
Yes.
for whatever you said, there's a question also. So if there is a RAD15, we had patients of PALP2, RAD15, these are also sensitive to PARP inhibition. And these also cannot be missed because they are not that sensitive like a BRCA. But yes, they are sensitive to PARP inhibition, and therefore doing the complete HRR panel is clinically very relevant.
Yes.
Okay. So we have any other slides? I think we have come to the conclusion.
Yes, one more case, sir.
Okay, I think Dr. Vinu will take up this. I didn't ask him for quite long. So Dr. Vinu, you can take up this case. This is Ruby, 65 years old lady, breast ovarian cancer diagnosed. You can see high-grade serous and also IDC positive. She underwent MRM, received radiation, strong family history, has not undergone any genetic testing, oncology expense parameter. Should HRR be done on this sample for her? So again, to simplify the question, do you take family history into consideration before sending HRR testing in your clinical practice in breast and ovarian cancer? Dr. Vinu.
For ovarian cancer, these days we are encouraging everybody to get tested for HRD, sir, irrespective of family history. So the family history does not come so much into question for ovarian cancer. And if you are doing HRD, I think the tissue sample we would prefer, sir, over the blood sample. I think HRD is more proven in the tissue sample only. And for ovarian, we really don't take family history. We are recommending for everybody these days, sir.
Very correct. I think that's true. Like in ovarian cancer, we are sending for all advanced high-grade serous. In breast also, there is a trend has been changing. After you had the overall survival benefit in the Olympia, we are trying to send for all early breast cancer who are HER2 negative for germline BRCA testing. But I agree, HRD is the way to go as far as ovarian cancer is concerned, because you will be able to pick the maximum number of patients. But HRD is expensive, as you know. So on those occasions, a germline HRR would be a reasonable option.
Yes.
Okay, I think excellent points. We did have a discussion. Okay, next slide. I think we can come to a conclusion and consensus.
Yes, I think this was the last case.
Okay, before I conclude, I can ask each of the panelists to say one line on HRR testing, what take-home message we can have. I would start from Dr. Mofazzel and then Dr. Rolan, Dr. Bijesh, and Dr. Vinu finally, and we can conclude the session.
Right. This discussion has been an excellent one, and I would recommend this testing, HRR testing for patients, particularly with breast and ovarian cancer. And again, in cases of pancreatic and prostate cancer as well, I'll be trying with this testing so that because they are the candidates for PARP inhibitor treatment, provided they can afford the testing cost as well as the drug cost. I will take consideration into the points I already mentioned earlier, because we don't have easy availability of the test, the cost of the test, and as well as the cost of the drug being proposed for the treatment if they are positive. And I will request Dr. Vidya to, when we send samples for testing of this BRCA1 or HR test, please give a line of conclusion mentioning your basic findings and the recommended drugs, not only PARP inhibitors, in other cases as well. I take this opportunity to request her so that the things become more easy for us to interpret in the clinic. Sitting in the clinic, you may not have the chance to go through 8 pages of reports. So I'll request that. And with I learned many things from this session. That is my point to mention in the conclusion. Thank you.
Thank you, sir. Yes, we'll do it, sir.
Thank you, sir. Thank you. I think very valid points. Dr. Roland, you can also say a few words.
Yes, for me, I would consider HR testing also for ovarian and for pancreatic because of the data from the clinical trials that are available, wherein HR and HRD status were showed benefit in choosing choosing the treatment for the patient. Although admittedly HRR testing is more expensive than BRCA 1 and 2 testing only, usually I would ask for BRCA testing first, and if it came back negative, especially if it's for ovarian, that's when I would advise the patient to undergo another test for HRR. For pancreatic and breast indications, I'd probably just ask for BRCA testing.
Okay. Thank you, Dr. Roland. Okay. Dr. Bijesh?
Yeah, thank you so much for this very elaborative and very nice session today. And I learned a lot. And now after this session, maybe I will start practicing sending HRR testing for prostate and pancreas too. Main problem for us is, as I already told, it's not done in our country, and it's because of the cost, and not only the cost of doing the test, but the cost of the medicine hinders us in doing the routine testing. But from what I have learned in these sessions and what I've studied, I think instead of just BRCA, I would go for HRR, which is more comprehensive, and it will be beneficial for the patient to give them PARP inhibitors if it comes positive. So that's my take home message.
Thank you, Dr. Bijesh. Really enlightening words, very impressive. Okay, Dr. Vinu, you can say, and then we can conclude.
Yes, thank you so much, sir. I think it is a very promising option considering pancreatic cancer, which has such dismal survival. Any drug which will give us an advantage will always be of a great help. And in prostate cancer, I think if it comes in second line, we may have a hormone positive breast cancer like model where we use targeted therapy first and move on to chemo later, which would be very interesting. And coming to ovarian cancer, to Vidya ma'am, I think we are very eagerly waiting for the HRD to be released because
Yes.
in ovarian we know HRR is not equal to HRD.
Yes.
So we are very much eagerly waiting for that, and I think it will be very interesting times ahead. Thank you so much. It was a great honor being a part of this panel. Thank you.
Thanks all of you for this opportunity. Over to you, Dr. Vidya, and we can conclude. Thank you.
Sir, thank you so much, sir. There is only one question in the question answer session for the panelists and the moderator. Does the Gleason score affect the criteria for HRR testing, meaning aggressiveness of the disease, or does it have any decision making in prostate cancer?
So, yes. So, there is no good, as far as I understand, there is no good correlation between the Gleason score and the BRCA, but usually BRCA have a high grade tumor. They will have a higher Gleason score than those which are not BRCA mutant. So they are high grade and they are exquisitely chemosensitive. They're exquisitely sensitive to PARP inhibitors. So they have a higher grade. Even if you look into ovarian cancer, they also have a high grade carcinoma. So that is what I can say. But I don't recall any a paper or a publication correlating a BRCA and a Gleason.
Okay. So moderate Gleason score is less than 7, sir? Or is there any kind of a range for the Gleason score?
6, 7, 8, and then 9 and 9. So this is how we use. So if it is 6, 7, something like low and moderate, and if 8 and 9, it's a high Gleason score.
Okay. 9 and above is considered as high.
Yeah.
Okay. Okay, sir. Thank you so much, sir. So, and there's a not so relevant a question here. Are PARP inhibitors, so this is something relevant probably. Are PARP inhibitors indicated as first line treatment if the patient is BRCA positive? This is coming from Somebody from LinkedIn.
I
It's a
think
very
this is,
generic question.
Yeah, I think this is in, I think he's probably answering in ovarian cancer. So
Ah,
in ovarian cancer, if you have a, what is that? If you have a BRCA
mutation.
positive,
Mhm.
okay, yes, definitely, yes. So if you have a BRCA positive, I think in any cancer, if you look into ovarian,
It's also in the NCCN guidelines for
Yes.
metastatic breast
Yes.
cancer.
First line setting.
The first line setting for metastatic breast cancer is that's BRCA positive, BRCA mutation positive.
Okay. So there is a different question related to the biology of the disease. When there are mutations in pathways impacting insulin secretion in pancreas, does it have an effect on mutations like PIK3CA, CTNNB1? I mean, it's just a, anecdotal experiences if you have any. That's one of the questions that was asked, but it's not relevant to the current context though. Do you have any sharing on this line, sir?
Yeah. So what was that, Vidya?
So mutations in the Wnt/beta catenin pathway in or the MAP kinase pathway in ovary, does it have an effect on the pancreas or insulin secretion, Wnt pathway? Because diabetes and then pancreatic cancer, there are some studies now. So, and the primary, some of other RAS mutations are the most common mutations in pancreatic cancer, MAP kinase pathway. Sometimes we might see the other signaling pathways. Does it have any kind of a correlation?
I think it's quite in a research way. It's not come up in a big way. I think we would await data making before making comments on
Yes.
this space.
Yes, agreed, sir. Okay, sir. So there are no more questions. And I would like to thank Dr. Chandrakanth, sir, and all the panelists here today for taking time off from their busy schedule of their OPDs and being here to share their knowledge and their experience while treating patients of different cancers and how they take forward when there is when there are patients with potential options for PARP inhibitor therapy. And thank you all, the audience who have come over here to listen to this wonderful session and an educational learning here. And have a nice evening. And we will see next in the next session where we would discuss some other interesting topic. Thank you all.
Thank you very much,
Thank you.
everyone. Thank you so
Bye-bye.
much.
Thank you and bye.
Thank you.
Bye-bye.
Bye bye.